certificate. And I request our patron, Dr. Parikh sir, to say few words of blessings to all the speakers, course directors, and participants. Dr. Parikh sir, will you bless us?
Good afternoon, friends, and I welcome everyone, especially our President-elect, Dr. Girish Mathur, Dr. Alkadesh Pandey. Unfortunately, she must be busy with some personal work. Dr. Prakash Keshwani, Dr. Minal, Dr. Padam Shri Gulati, and other colleagues who have joined today's program. I must congratulate and compliment Dr. Prakash Keshwani and Dr. Minal for initiating this very good educative program for our clinicians, and we would like to continue this program throughout the year. We may take other important topics of day-to-day concern to our clinicians. This will help to update our clinicians to their knowledge, and they become more aware about the problems. As Dr. Keswani said, that we can discuss cases also, complicated cases we can discuss, and we want to have panel discussions with the masters of their subjects. So this is also a very good idea to implement for disseminating knowledge. Today we have got three very important speakers. Initially, Dr. Minal will be speaking on thyroid disorders, then Dr. Ajay Shah, and then Dr. Saran, who are endocrinologists. So I request Dr. Minal to start with today's certificate program. This is also, this thyroid is also in this certificate program?
Yes, sir.
Yes, sir. Thyroid also?
Yes, sir.
So I invite Dr. Girish Mathur to say something.
Thank you, sir. Honorable Dr. K.K. Parikh, sir, my mentor and guide, and a source of inspiration to we all physicians of Rajasthan. And Dr. Prakash Keswani, Dr. Minal Mohit. It's really my proud privilege to attend this ambitious certificate courses on thyroid and male hypogonadism. I compliment and congratulate Dean ICP Dr. Alkadesh Pandey in taking the lead to start this innovative academic event. I'm sure it will immensely benefit the common practicing physicians in treating their patients in day-to-day practice. I congratulate the course directors, Dr. Prakash Keswani, Dr. Minal Mohit, for all their sincere efforts and hard work. Today, we have a very distinguished faculty in Dr. Minal Mohit, Dr. Ajay Shah, and Dr. Sanjay Saran, who are eminent endocrinologists of Rajasthan and of national repute. I wish the program a great success. Thank you so much again for inviting me to this important event. Thank you so much.
Thank you, sir. Thank you, sir.
Dr. Prakash Keshwani, aap bolenge?
Yes. Thank you, sir, for your blessings. You have always been, both of you have been the source of inspiration and motivation to us. And with this only I have been able to do these activities. And Dr. Minal is also very actively working and also a source for initiating my certificate course also. So thank you very much both of you. And I request Dr. Minal Mohit to start with his course so we can finish in time. Dr. Minal Mohit, please.
Thank you, sir. So, very good afternoon to Honorable Dr. K.K. Parikh, sir, Girish Mathur, sir, Dr. Keswani, sir. And thank you, welcome, Ma'am Shyam Sundar, sir, for this certificate courses that we have initiated. Today will be the second module of the thyroid certificate course. So, last Sunday, we discussed in the first class about the thyroid anatomy. And this is second module, we will be taking through the thyroid physiology. So, with your kind permission, this is we will be beginning with the thyroid physiology this Sunday. And as per the protocol, I have already posted the pre-test, the 10 MCQs to the WhatsApp group of thyroid modules. The last course pre-test was well attended by most of the participants, and it was really well done. So I congratulate all the participants who've been actively participating. And I've already received the answers for the second MCQ set also. The answer key will be declared after the test, after the module, after the session. So I just begin with your kind permission, sir, the physiology. So the physiology of the thyroid is something that the thyroid disorders can lead to a very lean, thin and weight loss person, and also the thyroid physiology or thyroid disorders can also lead to weight gain and obese individuals. So the thyroid metabolism or the thyroid disorders can take the seesaw on either sides. So just to understand how it all happens, first we must understand the relation between iodine and the thyroid gland. So how does iodine and thyroid gland are related? Thyroid gland contains almost 3 to 20 milligrams of iodine. And we are entirely dependent on a dietary source of iodine because we do not have any iodine formation inside our body. So we are only dependent on the dietary iodine sources. And the commonest source of iodine in our diet comes from seafood. And as we may not all be seafood eaters, so we have iodized salts available, and we even have iodized water. The water is also iodinized. So the source of iodine in our diet is either water or salt, and also the seafood. When we talk of iodinization of salt, the protocols, the government protocols are that we are adding 30 milligrams of either potassium iodide or potassium iodate per 1 kg of salt. So 1 gram of salt gives us around 30 micrograms of iodine. So if we require, our daily requirement, as we all know, is 150 micrograms. So if we require 150 micrograms, we must be consuming 5 grams of salt. This iodine is absorbed as iodide from small intestine. The recommended daily intake is around 150 micrograms per day, out of which 30% is taken up by the gland and 70% is excreted in the urine. So of the total 150 micrograms that we take, 105 micrograms is excreted in the urine, plus the thyroid hormone metabolism also re-releases the iodine in the blood, which is also excreted. So the net result is that we need to take in 150 micrograms every day through our diet, and we also excrete 150 micrograms of iodide daily in the urine. So the balance is well maintained. So the recommendations by WHO are that in children, it should be 90 micrograms. Between 6 to 12, that is the adolescents, it should be 120. As adults, the recommendations are RDA is 150 micrograms. During pregnancy, the need is increased to 200 to 250 micrograms. And during breastfeeding, it remains the same just like the pregnancy intake, that is 200 and 250 micrograms. So these values we almost all know. How do we actually assess the deficiency status? We assess the deficiency status by measuring the urinary iodine. So if the urinary iodine excretion is less than 20, then the patient is suffering from severe iodine deficiency. If we are having a urinary excretion of more than 300 micrograms per liter, then we are dealing with a significant excess or over intake of iodine. So what is the role of iodine? Iodine deficiency leads to TSH stimulation of the gland. How does that happen? Because of iodine deficiency, the hormone synthesis is halted. As a result, there is increased TSH levels in the system, and that goes and that stimulates the gland. So there is development of goiter, the huge goiter. Those are the large goiters that we have all seen in probably our grandparents and even a senior generation than that, when we were facing severe iodine deficiency. when the iodinization of the salt was not taken up by the government. That was the time when we were facing large goiters. So iodine has important role in preventing the goiter formation. Then during the pregnancy, we know that we studied in the last class that the fetal thyroid development begins from 4th week of gestation and is completed by 14th week of gestation. And the fetal gland starts synthesizing hormones only after 20th week of gestation. So iodine is also important for the normal fetal development and specifically in the CNS development of the fetus. Then iodine deficiency during pregnancy and in newborn can lead to the decreased IQ level because the brain development depends, the cognitive development depends upon the mother's thyroid balance, and the mother's thyroid balance is indirectly dependent upon iodine. And iodine deficiency is the commonest cause that we have come across, and we were having increased incidence and prevalence of cretins. So cretins were the children who were born with in areas of iodine deficiency. So iodine deficiency has been the cause of cretinism during iodine deficiency era. So by the government efforts, by the iodinization of salt and water, we do not come across these conditions very frequently now, but still there are certain hilly areas where we are facing iodine deficiency. Now, thyroid is a gland which is capable of concentrating almost 40 times iodine in the follicular cells. Now, there is a sodium iodine symporter. So this is a sodium iodine symporter, which we studied in the last class also. This is responsible for iodine shifting from the blood to the thyroid gland. This sodium iodine symporter is regulated by TSH directly. So TSH causes regulation of sodium iodine symporter mRNA. But other than TSH, this sodium iodine symporter is also regulated by iodide directly. So this is very important, as we will know that besides TSH, directly organic iodide can also stimulate sodium iodine symporter. So there is something called autoregulation. So once this organic iodide regulates sodium iodine symporter, which is independent of TSH, this is known as autoregulation. And this autoregulation is actually our first line of defense. So whenever we have a state of excessive iodine, this autoregulation shuts down the sodium iodine symporter. Whenever we are in an era or in areas of iodine deficiency, this autoregulation helps in activation of the sodium iodine symporter. So there is a preferable iodine uptake by the gland. Now, for some reasons, if this autoregulation fails, then there is iodide excess or deficiency. Whatever is happening in the serum will be reflected in the gland because this autoregulation has failed. As a result, because of iodine deficiency, we will land up with large goiters. So there will be iodine deficiency diseases. Whenever there will be iodine excess, then what will be the result? That will depend upon the underlying thyroid gland. So what are the sources of iodine excess at times? Most commonly, we have seen and heard of amiodarone. Amiodarone can lead to hyper. It can be type 1 amiodarone-induced thyroiditis. It can be type 2 amiodarone-induced thyroiditis. So amiodarone is a molecule which is prescribed very commonly by the cardiologists. So amiodarone is one common source of iodine which can cause excess iodine in the system. Then most of the dye, the contrast media that we are using for most of the investigations, the radiology, that is again a source of excess iodine in the body, the contrast. Then the betadine, which we are using at times, then the povidone iodine, which is being used. All these are sources of iodine which can lead to excess iodine in the system. Now, what happens if the iodine is excess? Suppose there is a lot of iodine in the system and your thyroid gland is normal. If the gland is normal, it will shut down the intake and it will just take up as much as required and the patient is not affected and the patient remains euthyroid. But in case the gland is already disturbed or there is already some damage in the gland which is already ongoing, in such a case, depending upon whether the gland behaves as a takes up the Jod-Basedow effect or it takes up the Wolff-Chekhov effect, it can land up with hyperthyroidism or it can land up with hypothyroidism. So what happens in hypothyroid or Wolff-Chekhov effect is that because of excessive iodide accumulation, the iodide blocks the further uptake of iodine. As a result, the further uptake is blocked and that leads to acute Wolff-Chaikoff effect. And later on, that same iodide stops or inhibits the organification of the thyroglobulin molecule, the tyrosine, organification of tyrosine. So there is no further formation of the thyroid hormones. So that leads to chronic Wolff-Chaikoff effect. At the same time, at times, it can lead to excessive stimulation and lead to excessive thyroid hormone synthesis and cause Jod-Basedow effect. So Wolff-Chaikoff effect is when the autoregulation fails and there is excessive intrathyroidal inorganic iodide concentration, which causes decreased organification because there is binding of this iodide complexes to itself. So there is reactive form of iodine complexes with iodine. So organification does not occur. So any condition which causes enzymatic block, it causes inhibition of the hormone synthesis and it also stops the further iodine entry inside the gland. As a result, we are facing something called iodide myxedema, or iodide myxedema is a condition of severe hypothyroidism because of excessive iodide in the system, and that is iodide myxedema by the Wolff-Chaikoff effect. Another condition is the Jod-Basedow effect. Here, because of excessive iodine, there is increased hormone synthesis, and that causes hyperthyroidism. And this condition is more common when we are already at the verge of facing conditions like Graves, or there are toxic adenomas present, or there is already a predomination or predisposition to the toxic MNG formation. So there is already a gland which is disturbed, which is defective, which is having toxic MNG, and they are subjected to excessive iodine by chance, and they'll end up with Jod-Basedow effect. Now, this Jod-Basedow effect can also cause hyperthyroidism, which can be a function of thyroiditis, and they might give you a picture of low radioactive iodine uptake. All these conditions, Graves, toxic MNG, and toxic adenoma, will give you the picture of increased uptake, whereas Jod-Basedow phenomenon, which might lead to hyperthyroidism in the absence of these conditions, will give you a picture of low RA, that is low radioactive iodine uptake. So excess iodine sources we have already started. Maybe it is dietary, maybe it is the contrast administered, or maybe it is a drug induced. That can be most commonly amiodarone. At times it is also lithium. So we do have conditions of excess iodine in the system. Now, what are the clinical uses of iodine? Clinically, we are using iodine, and the preparations available in the market are the colloidal iodine or the SSKI, that is saturated solution of potassium iodide. Then Lugol's iodine is available, and this is these iodine preparations are at times used for thyroid storm, or they are used pre-operatively prior to surgery when we need to control hyperthyroid patient in an emergency. Then in first-line therapy of hyperthyroidism, initially we were using this preparation. Most of the seniors, and even I have used this iodine in my practice in the cases of thyroid storm initially. Sometimes we are using or misusing the molecule to treat goiter and hypothyroidism, which is a wrong approach, because though iodine deficiency has led to hypothyroidism and goiter, still over-treating with iodine will not treat your goiter. This is about iodine and the gland. Now about the hormones in circulation. So once these hormones, as we studied in the last class also, that T4 is the 90% of the hormone which is synthesized inside the gland and released and secreted. So this 90% of the gland, that is 90% of the hormone T4, it is a prohormone. So this prohormone T4, it is released around 80 micrograms per day. And 6 microgram of T3 comes directly from the gland, and 3 micrograms is the reverse T3. So out of this 80 micrograms of T4, it is peripherally converted to the active form, that is T3, around 24 micrograms. So total 30 microgram per day of T3 is available or secreted in the system. Similarly, remaining 27 microgram of reverse T3 is peripherally converted from T4. So average serum levels are around 120 nanogram per dl of T3, 8 microgram per dl of T4, and 30 nanogram per dl of the reverse T3. Reverse T3 does not have any physiological role. This is a prohormone and this is the active form. So most of these hormones, they are released in the circulation and they are bound. They do not travel free. they usually travel bound to the protein molecules, that is the thyroxine binding globulin, 70% is bound to TBG. Then we have the transthyretin or the thyroxine binding prealbumin, which is carrying around 10 to 15% of the thyroxine, and albumin is carrying around another 15-20%. So the free form or the unbound form of FT4 is only 0.03%. And the active molecule is the T3, that is triiodothyronine, which is traveling unbound around 0.3%. So we have to remember the unbound, the free form or the active forms are very, very less, and they are the hormones which are active and they are required in the system. Conversion takes place majorly in the liver, but also in sometimes in the kidney and at the site of action, that is at the tissue level. This conversion we had studied last time is by the mechanism of deiodinase enzymes. So D1, D2, and D3. We had 3 enzymes, and D2 is mainly responsible for the active form. D3 is responsible for the reverse T3, and D1 is responsible for your thyrotoxicosis. So that we studied last time, the deiodinase. So it's a pro-hormone. So why is it a pro-hormone? And why the nature has given us this protection? Because T4 has a very long half-life. The half-life of T4 is almost around 7 days. So the distribution is 10 liters. Extrathyroidal pool always exists around 770 micrograms. So this prevents significant fluctuations in the levels of the hormone, because T3 has a very short half-life. Its half-life is only 1 day. So even when the T3 is not there, T4 is always available as a pool, and it is rapidly converted into the active form T3. So that is nature's way of giving us a stability or a stable availability of the active hormone. This is what we were talking, the deiodinase mechanism, D1, D2, and D3. So D2 converts into the active form, D3 converts into the reverse T3 form, and D1 is responsible for giving us the hyperthyroid status, because it acts both at the outer ring as well as the inner ring. So when we are using the anti-thyroid drugs, we know propylthiouracil is the molecule which we prefer when the patient is really very, very bad, because it also blocks the peripheral conversion. So when we talk of peripheral conversion blockade, PTU is actually blocking the activity of D1. So the T4 metabolism, around 41% gets converted to T3, 38% is converted to the reverse T3, and 21% is metabolized via other pathways and is excreted via bile. So this is about the thyroid hormones in circulation. Now coming to the relation of TSH, TRH, and how does the TSH and the TRH hormones, they are under the feedback loop. So this is the hypothalamus, and from the hypothalamus we get the TRH, and this TRH, that is the thyrotropin releasing hormone, acts on the anterior pituitary, and this anterior pituitary then releases the thyroid stimulating hormone, and this TSH then acts at the gland level and makes the gland release the active hormones, that is T3 and T4. Now there are a few important points that we will come across. So TSH, it is produced by anterior pituitary. The cells producing them are the thyrotropes. They constitute around 1 to 5% of the cells in the anteromedial pituitary. They are present throughout the life. They continue to produce TSH, and they do not regress with age. Stimulation stimulates several processes. TSH is responsible for the iodine uptake. It is responsible for colloid endocytosis, and also responsible for the growth of the thyroid gland. TSH is upregulated by TRH. So TRH, that is the thyrotrope releasing hormone. So thyrotrope releasing hormone coming from the hypothalamus, it upregulates the TSH. Then there is a negative feedback loop, or there is a down regulation of TSH by the T4, T3, and directly also, and because these glands also inhibit TRH, so indirectly they also down regulate the TRH. So TRH is inhibited, so ultimately TSH is also inhibited. Now this is interesting that leptin increases TRH. Patients always come and tell us that I am obese because of my thyroid. And we always try to tell them that it may be the other way around, the story may be other way around. Because you are obese, that is why your TSH levels are rising. Because the High leptin levels, they cause a rise in TRH and also cause a rise in TSH. Then the TSH patterns, though we say that we can assess the thyroid hormone throughout the day and they are not affected by your food intake, but the TSH patterns are still lowest in the noon and they are highest in the night before we sleep, and they start rising with waking up. So the pattern is almost just the same as other hormones. Then there is another interesting part, that is TRH is also prolactin releasing hormone. So whenever we see a rise in TSH and significant rise, this rise of TSH is mostly associated with rise in prolactin also. So hyperprolactinemia, whenever the patients come to you with hyperprolactinemia, always rule out the thyroid status, whether the patient is euthyroid or the patient is hypothyroid. Because at times it is the primary hypothyroidism and it is the TRH which is stimulating the prolactin also. Then dopamine is prolactin inhibitory, so dopamine also inhibits TSH. So TRH is responsible for TSH and prolactin release, whereas dopamine is responsible for inhibition of both prolactin and TSH. Now TSH has two units, alpha and beta subunits. This again is very important because when we discuss pregnancy, we will come to know that because of this structural homology, the TSH has alpha and beta subunits, and this alpha subunit is common. This alpha subunit is common for TSH, LH, FSH, and HCG. As a result, during pregnancy, when HCG levels rise, this HCG, because of this alpha unit homology, also stimulates the TSH receptors. And so at times you will find that the hormone levels rise. And because of the rise in hormone levels, there is a feedback inhibition of TSH. Also because of the structural homology, there is TSH drop. So there is a low TSH, especially in the first trimester. And though the patient is euthyroid, the clinical picture is that the TSH is very, very suppressed and the reports are misinterpreted as hyperthyroid. So HCG can also stimulate the TSH receptors. Then this is the correlation of diabetes and thyroid, that whenever there is glycosylation of TSH, then again the bioactivity of the hormone is affected. As a result, the glycosylation, whenever the diabetes is worsened, there is increased incidence of hypothyroidism also. So we have seen the relation of obesity and hypothyroidism. We have seen the relation of diabetes and hypothyroidism. And we have also understood the picture of hyperthyroidism, the factitious hyperthyroidism during pregnancy, that is a suppressed TSH because of the rise in HCG. So this is how it works. So this is a feedback inhibition by the hormones T3 and T4. They are causing a feedback inhibition. The T4, it is converted by the deiodinase 2 into T3. T3 then inhibits the TR beta receptors here, and this is hypothalamus, and there is inhibition of the release of TRH. Normally the TRH causes stimulation of the TSH, but with this hormone feedback loop inhibition, there is inhibition of the TSH release. So this is TRH, which is causing stimulation of the anterior pituitary, causing release of TSH, and this TSH has a positive influence on the gland, causing release of the hormone T4 and T3. And T4, T3 then have a negative influence or a negative feedback loop inhibition at hypothalamic level as well as at the pituitary level. So this is a feedback loop. Most of the endocrine hormones follow a feedback loop system, and most of them are negative feedback loops. Now the TSH response to the change in T3, T4, again we have started. The lower thyroid hormones will make the TSH go high. High thyroid hormones will cause TSH to go down. So there is negative feedback loop. Then the TSH level, this again is important to understand that TSH levels will walk later than the T4. So TSH levels will take few weeks to change. So whenever we change any dose of the hormone, thyroxine replacement, we always follow up the TSH only after 4 weeks. So it takes 4 to 6 weeks for TSH to stabilize and come to the new changed level. Long-standing hypothyroidism will produce thyrotroph hyperplasia. So untreated patients on long-standing hypothyroidism will cause very high rise in TSH, and because of the increased TSH levels, there is a thyrotroph hyperplasia, and this thyrotroph hyperplasia might be mistaken on MRI as a pituitary tumor. But we have to remember a pituitary tumor producing large TSH, a high amount of TSH, that is TSH adenoma, will always be accompanied by a hyperthyroid clinical picture, because the TSH adenoma will give you a high thyroid hormone, the thyroxine hormone also. Whereas a hypothyroid patient will have a high TSH, thyroid hyperplasia, and a pseudo tumor of the pituitary, which will be a radiological image because of the hyperplasia. But FT3, the free T3 or free T4 hormones will be very, very low, and clinically the patient will have myxedema. So relationship between free T3 and free T4 and TSH is genetically determined, and this relationship is log linear. So up one parameter change of T4 is associated with a 10 times or 100 times parameter change in TSH. So a small change in T4, you can see the range. If the T4 changes from 0.5 to 5, it will not change to 0.5, of course. But if it moves from 1 decimal, the TSH will move by 100 points. So there is a log linear relationship, and this log linear relationship is important because that helps us to achieve a very precise and tight physiological control of the thyroxine hormone. So this is important, and this is all the nature's physiology, which has been very beautifully established, and this helps us to control the entire thyroid hormone and thyroid hormone metabolism. So now, what is the normal metabolic role of these glands, these hormones? Thyroid hormones are necessary and responsible for growth, differentiation, sexual and mental development. They regulate the rate of metabolism. So they are required for growth hormone action. They are required for mitochondrial oxidative phosphorylation. They are also required for the activity of adrenal medulla. They induce enzyme synthesis. As a result, stimulation of growth of the tissues, metabolic rate, along with increased heat production. So they are calorigenic hormones actually. One of the most important roles of T3 is that they act on the sodium potassium ATPase pumps. We know that almost 1/3 of all ATP in the body is actually used by sodium potassium ATPase. Now this T3, it increases the synthesis of sodium potassium pumps, and they also increase the ATP consumption. As a result, they also act on mitochondria to increase ATP synthesis. So ATP synthesis is increased, ATP consumption is increased by increasing the synthesis of sodium potassium pumps. And this is calorigenic. This helps us in maintaining our body temperatures. Even when we are into the extremes of temperature, very cold, our body temperatures are maintained because of the action of thyroid hormone. So they stimulate heat production in the body, which is secondary to increased oxygen consumption. As a result, the thyroxine hormone is also increasing our BMR. That we all know that in hypothyroid patients, the BMR is reduced. And that is why there is cold intolerance in hypothyroidism, whereas hyperthyroidism is associated with heat intolerance and weight loss. But there are certain exceptions. Our brain, testes, lymph nodes, ovary, uterus, and anterior pituitary, these are not dependent on thyroid hormone for heat production or the calorigenic action. They are not dependent on thyroid hormone. Then this is another important part, that why our euthyroid status is actually required. Our euthyroid status is helping us in maintaining the basic energy intake and energy loss. So in physiological concentrations, it is anabolic and it is causing a positive nitrogen balance. But whenever there is a disturb in the physiological balance and we end up with a hyperthyroid state or increased concentration of the thyroxine hormone, then it becomes a catabolic state. And then the patient starts losing weight, there is negative nitrogen balance, there is loss of muscle mass and significant muscle weakness, and there is proteinuria, and that is very commonly manifested in the hyperthyroid patients. So there is loss of muscle mass, there is proteinuria, and there is weakness, loss of even bone mass because of increased catabolic action of the thyroid hormones, and there is a negative nitrogen balance. In glucose metabolism or in the carbohydrate metabolism, again, we know that some amount, 50% of the carb intake is very essential because carbohydrate is required for the normal peripheral conversion of T4 to T3. At the same time, this thyroxine hormone or T3, it is also responsible for the proper carbohydrate absorption. So glucose absorption from the GIT is actually dependent upon the availability of the thyroxine hormone. Then there is accelerated glucose metabolism. There is increased glycogenolysis. There is increased glycolysis. There is increased insulin secretion. So it actually affects the carbohydrate metabolism also. And a patient with hyperthyroidism and hypothyroidism both have poor glycemic control. So this is because of the metabolic effect of the thyroxine hormone, that is carbohydrate metabolism, the glucose metabolism. Effect on fat metabolism is there. So it helps in mobilization of the fat from the adipose tissue. So this fat is mobilized from the adipose tissue, and there is increased levels of free fatty acids. So this free fatty acids, they undergo increased oxidation, and enhanced oxidation will cause, again, there is calorigenesis, there is decreased LDL, decreased triglycerides, decreased cholesterol, and decreased phospholipids. Again, you look at the picture the other way around. If all this is halted, if all this is stopped because of hypothyroidism, then the typical patient of hypothyroidism is presenting to us with dyslipidemia. And the picture of dyslipidemia and hypothyroidism is again raised triglycerides and raised LDL. And in cases of hyperthyroidism, we find a patient with a very low triglyceride values. So this is the patient which was before, and this is the patient after developing a state of hyperthyroidism. So there is all fat loss. I'm not saying that we should convert all our patients to hyper, and we should not be using the misuse of the molecule to regulate dyslipidemia, but this is the clinical disease scenario that the patient develops hyperthyroidism and there is associated weight loss. Now there is decrease in the plasma cholesterol because of increased secretion in bile. So the plasma cholesterol levels drop. Even before the BMR increases, that happens because of the action of the thyroxine hormones, which is independent of oxygen consumption. And as a result, hypothyroid patient presents with elevated cholesterol levels, elevated triglyceride levels. And before treating dyslipidemia, if we treat hypothyroid, we can correct the dyslipidemia. Even the vitamin metabolism is affected by the thyroxine hormone. Thyroid hormone increases the quantity of certain enzymes, and many of the vitamins we know they are acting as coenzymes. So vitamins are essential as part of enzymes and coenzymes, and they increase the need of vitamins. So hyperthyroid patients are also deficient in most of the essential minerals and multivitamins. Even the water and electrolyte balance is affected because we know that there is increased heat loss, there is increased sweat, so there is disturbed water and electrolyte balance also. As a result, hyperthyroid patients are also dehydrated, and hypothyroid patients have a lot of water retention. So they are having that subcutaneous edema. As a result, we find that the metabolism is significantly affected. Then there are certain permissive actions of these thyroid hormone, which may not be directly related or may not be studied directly, but then these glands and these hormones definitely have certain permissive actions. So they have stimulatory effects on epinephrine, norepinephrine, even glucagon, cortisol, and growth hormones, on gluconeogenesis, lipolysis, ketogenesis, and proteolysis. So they are affecting almost the entire metabolic pool. Even sleep is affected by thyroxine hormone because of the exhausting effect, because these thyroid hormones, they are exhausting, or they're making you lose your proteins. So there is loss of muscle mass. There is exhaustive effect on musculature, also on CNS. So hyperthyroid patients, they find it difficult to sleep because of the constant feeling of tiredness and muscle pain. Also, there is excitable at the synaptic junctions. They have excitable effects of the thyroid hormones at the synapses. As a result, even there is a difficulty to fall asleep. So sleep pattern is also affected with thyroid disorders. Even if you look at the other way around, in hypothyroid patients, they very easily fall asleep every moment. If you allow them to sit, they're always feeling drowsy and more sleepy because they have slowed down the synapses. So this is about the physiology of the thyroid hormone, hormone synthesis, gland, and all details about the iodine and whatever we can talk of thyroid physiology. With that, I think thank you so much, sir. And we can take up any questions if we have anything to discuss.
Excellent deliberations about thyroid, and each and everything, I mean, minute points have been taken. And I think it is very, very important to know, because it is not only thyroid, it is the all metabolism of the body which affects whether it is hyper or hypo. I think you have very nicely and very excellent presentation about thyroid hormone. So if there are any questions from the delegates, please don't hesitate to ask each and everything you want to clear, because this is very important. We have got still 15 minutes of the time. We can discuss all these things.
Ma'am, can I ask a question here?
Yes,
Please,
sure.
please go ahead.
So since we have discussed here कि urinary iodine is important, can urinary iodine test be done in pregnancy, मतलब to rule out whether a pregnant woman is deficient in iodine or not, routinely?
We can do that, sir, but nowadays actually we are not doing it clinically. We can do that, but actually we are not doing it because we are not trying to establish iodine deficiency after the iodinization of the salt and water. Hardly we come across iodine deficiencies as such. So though there was an era when the iodine deficiency was the leading cause of hypothyroidism, but nowadays it is autoimmune conditions which are taking the first place. So we are rarely dealing with iodine deficiency, but if you are suspecting iodine deficiency as the cause of hypothyroidism, then surely you can establish that.
My second question is that you told that requirement of iodine in the pregnancy increases. Suppose normally it is 150 microgram. In case of pregnancy, it is 200 or more approximately.
Yeah, that we know since our very childhood days, beginning of our college days.
Okay. Does it mean that we should increase the table salt amount in those cases where suppose the seed food or water the content water is not giving the sufficient amount of iodine in those areas?
Sir, I'm not sure of increasing the salt intake because we don't want our women to end up with pregnancy-induced hypertension or any other complications during pregnancy. But definitely the daily routine intake of salt in Indian food and including the water intake is sufficient to provide the required iodine. We are not actually dealing with iodine deficiencies anymore, as I already told you. And we never recommend them to take increased salt intake just for the iodine supplement needs to be increased. It is already sufficient in the salt and the water that we are recommending, though we are not taking besides salt and water. It is also provided some part also comes even from our dairy products. So milk, cheese, and all these buttermilk, the paneer, tofu, they also have some iodine. So the daily requirements in a very what you call a replete patient is hardly compromised.
And should we give any vitamin supplement to the hypothyroidism patient, since you're telling ki vitamins?
Yeah, that we do, sir. That we always do, because most of the patients are already those who are having hypothyroidism or hyperthyroidism, either of the cases. They are the catabolic states or even the slow down states. So we are always replacing them with vitamin D also and B12 also, niacin specifically. B3 is very deficient because it actually eats away. It actually takes away all your multivitamin and mineral and vitamin sources. So we do supplement all patients on hypothyroidism with thyroxine replacement. We are also giving some backup supplements also.
Thank you, ma'am. Thanks a lot.
Okay.
Can I ask you one question? What about the water content, iodine content in water? Because nowadays we have got different water, bottled water, then RO water, and then tap water. So can you tell us about the, is there some difference between iodine in the water?
Sir, I'm not sure, sir. I'll have to find out.
Because we knew that RO water takes minerals and iodine out of them. I mean,
I'll have to find out that, sir.
another question. can you tell us the very important points to remember when a patient has got diabetes and thyroid, hyper or hypo? What to remember when you investigate a case, and what is the cutoff value of thyroid hormones in those cases?
Sir, whenever we are having a patient of, say, let's begin with a patient who is coming to us for the first time with diabetes. On the very first evaluation, we always assess patients for thyroid functioning also. And we establish a euthyroid status. If the patient is euthyroid and also there is no family history, and we are not suspecting any autoimmune, or even if we have ruled out the anti-TPO status, then we may not follow up every year. We can follow up every 5 years or every second year or third year. But if the patient comes out to be hypothyroid or hyper will actually come as a clinical presentation. Hypothyroid or subclinical hypothyroid is something that comes up on a routine investigation. At that point of time, again, coming back to the family history, if the family history is positive or anti-TPO status is positive and the patient is subclinical, we can treat them or we can follow them up. If the patient comes out to be anti-TPO positive, then we follow them up. And if it is patient is symptomatic, then we treat also. The cutoffs are the standard cutoffs that we follow: TSH 3.5 microunits per liter. And we are usually following with TSH and T3, T4, the complete thyroid profile. So TSH cutoff we keep as 3.5 for the adults. For pregnancy, cutoffs will be different, of course. So when we are treating with hyperthyroid, we treat mostly with antithyroid drugs. And again, we try to bring the TSH levels to the normal within 2 years or 2.5 to 3 years if we are treating with antithyroid drugs, or we are subjecting them to radioablation, depending upon whatever the clinical picture is. But most common association is of type 2 diabetes with hypothyroid. Hyperthyroid presenting as just a coincidental finding is very, very rare. Mostly hyperthyroid patient will come to you with thyroid dysfunctioning, but hypothyroid will be an accidental or incidental finding, especially the subclinical picture or even the borderline TSH of 12, 15, 20 to 20 can be just an incidental finding. In such cases, we do treat them. And if in subclinical cases, we establish the anti-TPO, the autoimmune status, and then we treat them. And the cutoffs we always carry as 3.5. Though in very old generation, like above 70, we are not treating the subclinical cases of TSH up to 6 or 7 also. But in the younger population, we are treating that subclinical cases if they are symptomatic, if they are anti-TPO positive, and we are trying to keep the TSH up to 3.5.
So your message is that every patient of diagnosis, when we diagnose a patient of diabetes, we must also evaluate for thyroid functions. Every patient of diabetic patient should also be looked for thyroid function.
Thyroid functions. Yes, sir.
Because many times we miss getting his thyroid function in patients with diabetes.
Dr. Padma wants to say something, sir.
Yeah, Dr. Minal, very nice, very lucid presentation. I just wanted to know what's the reason for hypothyroidism becoming so rampant these days. You see the entire family being hypothyroid despite, like iodine deficiency has been taken care of by iodinated salt and other things. So what do you think is the cause for such an increasing number of every third patient turns out to be hypothyroid?
Ma'am, it's very difficult to comment that why it is happening. Maybe one thing is that we are more vigilant. Maybe we are screening more often and more frequently. Maybe the media has hyped it that patients at times on their own self-reporting also, they just get themselves assessed and then they come to you with reports already. And one in the family test, then the entire family gives a sample. So maybe the reason is that we are looking for more for it, so we are finding more of it. Otherwise, the increasing prevalence or the increasing incidence, why is it so, is very, I am not sure why, what should I answer, why it is happening. But yes, it is happening. That is very true. We are having equal burden of diabetes and thyroid nowadays.
Is there any role of chemicals?
Maybe we are looking more for it. So
Whatever is
Like
vegetables and
we can definitely say, yeah, we can. The environmental hazards, the endocrine disruptors. We definitely cannot rule them out. They can be there.
Use of pesticides. And then this is
Perfect,
very
yeah.
important. Yes. No. The reason for the whether the increased number of diabetic patients, increased number of hypertensive patients, increased number of thyroid patients, it is all because now better facilities, patients are aware, doctors are also aware about the disease. So the investigation, the frequency of the investigations has definitely improved and increased. We all see in our OPD that patients getting now today, they are ready for almost all investigations we prescribe them. Previously, they used to be have a negative approach कि नहीं कोई जरूरत नहीं कराने की सर कुछ नहीं है आज भी है पर जो investigations की बढ़ती है that is the important reason.
Lifestyle also, so lifestyle is changing, and we have also seen the relation of obesity is increasing. So there is a subclinical hypothyroidism also more prevalent. There is
Obesity
increased
is one of the important
diabetes. So
cause.
glycosylation is causing increased subclinical hypothyroidism. So subclinical hypothyroidism is now more of a life becoming related to your lifestyle also. So that can also be one reason.
Should we also test thyroid functions in cardiac patients, as you rightly said that codron is one of the important drugs to lead thyroid disruption, and and which is commonly used in patients.
Yes, and every AF patient should be evaluated for thyroid function. Every patient on amiodarone or cordarone is the brand name should be evaluated for thyroid function almost every 6 monthly or at least once a year, because this is very common, and amiodarone can lead the swing anywhere to hyper, to hypo. It can be autoimmune type 1, it can be autoimmune type 2. So amiodarone induced thyroiditis is a very prevalent and commonly known entity. Similarly, the patients on antipsychotics, they deserve a thyroid evaluation 100%, because many a times a subclinical hypothyroid patient is treated as a depression case, and the per se diagnosis of thyroid is missed. So there are two questions in the chat box. One is Dr. Geeta ma'am has asked for role of anti-TPO antibody in daily practice. Ma'am, the role of anti-TPO will be taken up, of course, when we are talking about the report interpretations in the next class, maybe. But as you have asked here, just let me be very precise as we're running short of time. But anti-TPO antibody has a definite role. Whenever we are dealing with subclinical hypothyroid, we try to rule out the status of the autoimmune status of the patient. So if the patient is having autoimmune positivity and subclinical hypothyroid and asymptomatic, then you can just follow up the patient, but keep the patient under follow-up, because anti-TPO positive patients have a very high conversion rate. And if the patient is anti-TPO negative, then you can just stay relaxed. You may not follow up the patient routinely. You can focus on treating the patient for obesity or maybe for diabetes, and may not focus so much on hypothyroidism. So anti-TPO antibody has a role specifically in subclinical hypothyroid patients, and in cases of pregnancy also we prefer using anti-TPO antibody to rule out whether the woman is more likely to have autoimmune condition, as she may pass it on to her next generation also. So anti-TPO antibody has a significant role at certain specific times. Then we have another.
I think Dr. Alka ma'am has already come in ICP.
Yeah, ma'am. Good afternoon.
Dr. Alka Deshpande. Dr. Deshpande. Continue. Yes.
One last question, Dr. Minal. I just wanted to know how much is the urinary iodine excretion in iodine sufficient population? Is it more than 10?
As much as the intake, as much as the excretion. Because as I told you, there is some hormone catabolism, and some 30% is taken up by the gland, 70% is excreted. But that 30% comes from the daily catabolism of the hormone. So whatever is your intake will be your excretion. Dr. Bodhya Staff Munshi, Can you kind of revise the clinical application of TSH-T4 relationship while treating both hyper and hypo with case examples? We can definitely take the TSH-T4 relationship in hyper and hypo when we are taking the report interpretation. And if you want case-based approach of all the cases, we can definitely take up the report interpretation class exclusively as case-based, because this was absolutely theory, anatomy and physiology of the gland and the physiology of the hormones. There was no way to take it up as case-based. But definitely from now, third class will be report interpretation and clinical examination. So that will be definitely.
That is better. That will be better to understand about the how we should interpret thyroid hormones.
Sure.
So this is very important. So later on, after this, we finish this. We will take this case-based discussions also. So Dr. Keshwani, your
Yes, sir. Yes, sir.
Thank you, sir.
And congratulations, Dr. Minal, for nicely presenting thyroid hormone physiology. And I really think that you must have been on the other part of the medical side. You must have been in the teaching side in the medical colleges. You take so very good classes, and physiology of thyroid hormone synthesis, various factors were described very well.
Thank you so much.
Congratulations once again. Now we move towards the second certificate course, that is male hypogonadism. And today we have very eminent two endocrinologists from Jaipur for taking the course forward. And first one is Dr. Ajay Shah, is DM Endocrinology and Chief Endocrinologist of Santokba Dulladji Hospital. And he will be deliberating his talk. And without wasting much of the time, I invite Dr. Ajay Shah to please start and share your screen.
Thank you,
Dr.
sir.
Ajay? Yes.
Let me first share
Most
my
welcome.
screen.
Yes. So you have already shared, I think. Oh, you share the screen, yes.
Okay, my slides have come up.
No, not yet.
I can see my slides.
Yes, but it is not visible to us. Correct?
Now?
No, they are not allowed, and they are not visible, and you have been allowed by our IT team. You can again go for the screen share.
Okay. Just give me 1 minute.
Sure. No. No, not yet.
अजय से कहिए ना, वो बता देंगे.
Actually, light as in Jaipur today, there is a rain.
My internet connection also failed, so I am running with the mobile.
Yeah, I have done the same thing, and I think that is the precise reason why, this is.
Yes, it is now there.
Very good. Make it full screen, please.
Yeah.
Good. Very good.
Okay, now they have come up.
Very nice. Very good.
Okay, So thanks to Dr. Keshwani and Dr. Parekh for allowing me to present with male hypogonadism, because this topic is shrouded with confusion and myths, particularly not just in the general public, but also amongst doctors. I'll be talking about the clinical presentations of hypogonadism. So Dr. Minal was just talking about physiology, and I thought as a prelude to the main part of the discussion, which is the clinical presentation, I thought for easy understanding, it is better to run through the physiology, the hypothalamic gonadal axis, so that things become much more clearer. So there is a hypothalamic area in the brain, which is thought to be the pulse generator. And this pulse generator secretes the gonadotropin releasing hormone, which acts on the pituitary gland, which secretes the gonadotropins LH and FSH, which further act on the testis of the male. And this LH and FSH act on different parts of the testis. The FSH mainly affects the seminiferous tubules, the Sertoli cells, to enhance, start, and promote spermatogenesis, although there is a permissive role in generation of the male hormone, testosterone, which is predominantly done by the Leydig cell in the testis, but which is predominantly controlled by the LH hormone. So like all other endocrine organs, there is a robust feedback mechanisms, and the testosterone that is secreted from the testis gives a negative feedback both on the hypothalamus and on the pituitary gland, so that whenever there is an excess or whenever it is inappropriate, inhibitory signals are signaled to the hypothalamus and pituitary. How does this translate clinically? The GnRH is secreted in a pulsatile form continuously after puberty, although it is secreted at other times also, which I will be telling. And because it is secreted in a pulsatile fashion, similar is the fashion of secretion of LH and FSH, which are secreted from the anterior pituitary in short pulses. The clinical application of this fact is that whenever we want to measure the gonadotropins, LH and FSH, it should be a pooled sample, which means sample should be drawn every 20 minutes for 3 consecutive samples. Although modern day sampling, modern day techniques, particularly the CLIA, chemiluminescent assay, are quite sensitive. Even a single sample is sufficient enough, but the older generation assays, particularly the RIA, radioimmunoassay, required pooling of the LH and FSH. That's the clinical relevance. And whenever there is hypothalamic injury or pituitary injury, which occurs in secondary hypothyroidism, as you can see, the levels of LH and FSH, they are blunted and become undetectable most of the times. However, in the other situation, wherever testis is the main culprit organ for hypogonadism, because of lack of inhibition, which is registered by testosterone on hypothalamus and pituitary, the GnRH and LH and FSH are sky high. The FSH level, particularly, even the baseline values are quite high. If you could appreciate the LH and FSH curves from normal to the primary or wherever testis or gonad is affected, the levels are sky high. And I was talking about the timing of the testosterone. And this is very, very important to understand, because the clinical manifestation of hypogonadism are an extrapolation of this curve. As you can see, the testosterone is secreted at 3 points in a lifetime of a male. First is in utero, in the fetal life, and the testosterone starts being secreted at the end of second trimester. It lasts there, and by the end of third trimester, the levels fall, after which there is again a surge of testosterone, which is commonly referred to as mini puberty, which can last up to 6 to 8 months in the infancy. And after that, we all are familiar with around 12 or 13 years, testosterone surge sharply increases and testosterone levels remain high until the 7th decade, and at which time the levels could be measured. And this forms the basis of the clinical manifestation and easy understanding of what is happening to the patient. Just I wanted to tell you that the gonadal steroids that are secreted in male are predominantly testosterone, which affects the external genitalia, and it also affects the larynx, muscle, bone, and very importantly, brain. These are the sites of action of testosterone. Metabolically or physiologically, this is converted into dihydrotestosterone, the action of which is on scalp hair. And we all know that why some people become bald and they relate the balding to hypogonadism is because of this fact. Some internal sex organs are controlled by DHT, dihydrotestosterone. Maybe at a later date, these could be discussed. And testosterone in the subcutaneous tissue gets converted into estradiol, the female hormone, which is responsible for, which acts on the breast. And this diagram, if you just see it, it is easy to capitulate what would happen if the testosterone levels are low. So the actions of testosterone are on brain. Now this is important because the action of testosterone starts from the infancy, where there is the initial surge of testosterone, and this has been well studied in various studies. For example, 1-year-old boy and 1-year-old girl, the choice of toys in that 1-year-old infant, if it's a boy, it will be either a gun or a car. But if it is something like dress or a doll, it is a girl. And this shows the testosterone effects on brain, which means testosterone causes aggressiveness, cognition, and of course, libido. All of us are very familiar with the testosterone actions on the sexual organs, the libido, penile growth, spermatogenesis, but it also affects various other parts, the fat, liver, muscle, the bones, particularly the BMD maintenance, and erythropoiesis through actions on kidney and on the marrow itself. So the clinical manifestations in male hypogonadism pertain to features because of low testosterone, or features pertaining to specific etiology and the associated clinical features, which I'll be discussing slightly later. So first, discussing the features of low testosterone are extrapolation of whatever physiology that I have tried to discuss. And hypogonadism because testosterone is secreted at 3 points in a male: the fetal time, the pubertal time, and during the adulthood, signs and symptoms will develop at these particular points if testosterone deficiency occurs during these particular signs. So during the fetal development, if testosterone is not produced, it can result into impaired growth of the external sex organs. And this could result in ambiguous genitalia, female-looking genitalia, and underdeveloped male genitalia. It could be something like cryptorchidism, either unilateral or bilateral, maybe varying upon the site. If it is severe, the cryptorchidism could be abdominal, intra-abdominal, or at any point in the descent of the testis. And if the internal, I told you the DHT, if it is defective because of enzyme defect, sometimes ambiguous genitalia can also be there, and rarely and occasionally an endocrinologist is summoned just to ascertain the sex of a child. That is when hypogonadism could be easily suspected, because during the fetal development, testosterone is not secreted. The second surge of testosterone occurs during the infancy, where if it does not occur, sometimes cryptorchidism can occur. And the last surge of testosterone occurs after puberty, to which everyone is visible, are the changes when a boy becomes a man. And mind you, amongst the whole animal kingdom, this pubertal development is allocated to mammals alone. So that is how the nature occurs, and it forms a preparation for adulthood. Whenever testosterone is lacking or fails to rise during puberty, there is poor muscle development, the voice doesn't crack, there is failure of appearance of body and facial hair, which is one of the common presenting symptoms of low testosterone during this age. And of course, the patient or the parents are quite concerned about the size of the external genitalia. But very importantly, the signs that as physicians we should be looking for when such a presentation occurs is the eunuchioid proportion, because a lack of testosterone fails to unite the epiphysis. Somehow there is excessive growth of arms and legs, which are the long bones. They grow out of proportion to the trunk, which is called eunuchioidism, and the development of the breast in males called as gynecomastia. These are the pubertal stages that we learn about. And at stage 2, whenever testicular volume becomes more than 4 ml, we know that testosterone has started to rise. And this is the first sign of the puberty clinically. The surge in height in males is the second stage of the puberty, unlike in females, where along with the development of the breast, the height surge occurs almost simultaneously. So in a male patient, if there is failure of growth of testis beyond 4 ml, which is measured by an orchidometer, and the pubic hair and the penile length development are lacking, we know that we are dealing with hypogonadism. And of course, in the adulthood, once the puberty has attained, all the other sites where I had mentioned about testosterone actions, they will manifest. And we can broadly classify the actions of testosterone on physical development, psychological development, the brain that I told you, and the sexual development. And it is easy to envisage that in adulthood, low testosterone states, there would be decreased muscle mass, gynecomastia. And if hypogonadism develops very abruptly, for example, testicular surgery done for prostatic cancer, the male can experience hot flushes similar to a menopause in a female, reduced shaving frequency, but very importantly, the psychological disturbance is also very subtle and should not be missed. Some males become depressed, there is fatigability, failure to concentrate, and of course, the sexual complaints are overwhelming in adults, low libido, sometimes even marital discord can occur, and erectile dysfunction, and of course, in the younger age group, infertility can be a presenting feature. In a later stage, apart from the physical, psychological, and sexual clinical features that I have just mentioned, metabolic effects of low testosterone have been recognized in last 3 or 4 decades, and development and attribution of the visceral obesity metabolic syndrome are attributable to low testosterone because of the changed structure that occurs because of low testosterone. It's an academic exercise to differentiate whether hypogonadism is pre-pubertal or post-pubertal, because treatment remains the same, although there are some clinical features, for example, low testicular size or low external genitalia and eunuchroidism are telltale signs that the hypogonadism is pre-pubertal. And if there are metabolic features, loss of libido, oligospermia, perhaps these reflect an adult stage low testosterone. So the features that I just described pertain to features of low testosterone. There are certain etiologies where hypogonadism is pertinent, have very specific features, and I would just like to highlight anosmia and hyposmia. And I would like to remind you that apart from the taste, which was a new symptom that was developed that we saw in the COVID pandemic, hyposmia and anosmia could portend hypogonadism in a male patient. And it suggests hyposmia would mean a Kallmann syndrome. That means the pulse generator, along with this, the olfactory tracts. Many of you who might have attended last week's lecture by Dr. Shailesh, he had mentioned about Kallmann syndrome. Anosmia is quite specific for this, so that if there is anosmia, hyposmia with hypogonadism, you know that we are dealing with Kallmann syndrome. Then there are certain syndromic features which can tell about hypogonadism. A short, obese, hypotonic infant with specific features, we know we are dealing with Prader-Willi syndrome. But if we are dealing with a tall, polydactyly young boy, we might be dealing with LMB syndrome. And there are various other syndromes, particularly particularly the Klinefelter syndrome. And I assume in our next talk by Dr. Saran, he describes these syndromic features very well, so that if there is a syndrome, there could be features pertaining to that syndrome, and we can be helped by these features in determining the etiology. Of course, if there is headache, visual defects, we know that pituitary gland is involved. Most commonly, it is the pituitary adenoma that occurs, although any other SOL can also lead to same headache and visual defects, which can lead to the hypogonadism. Infection and trauma are self-explanatory. here I would like to tell that in cases of head injury, pituitary is involved in about 30 to 35% patients, and patients where there is no trauma to the genitals, perhaps you can still have hypogonadism because of injury to trauma. I would also like to state that there are some infections which can involve both pituitary, hypothalamus, and the testis simultaneously. Tuberculosis is very rampant in India. So tubercular orchitis or epididymitis, sometimes mumps can affect, and very importantly, sarcoidosis can affect both, so that you can have a mixed picture of them. Lastly, I would mention about associated clinical features, and these are conditions where hypogonadism is subtly present and the patient presents with features of the underlying disease. For example, a patient with alcoholic liver disease will have features of cirrhosis. And if you try to be an academician, hypogonadism could be manifest even clinically by presence of gynecomastia in these patients. And there are settings and backgrounds in which you know that perhaps hypogonadism is there. But in this group of patients, hypogonadism is on the background. So, dear friends, I would just like to state that clinical features of hypogonadism reflect the underlying physiology of the hormones. And I would like to state that they may be present in the severest form to the mildest form, and there is a spectrum that needs to be kept in mind based on the degree of the defect that is present. And I would like to reiterate that hypogonadism starts at 3 stages of life. If it is in the fetal state, the patient can present as cryptorchidism or microphallus, or if it appears in puberty, failure of appearance of the pubertal changes, the facial hair, breaking of the voice, and failure to develop the external genitalia, all of them are telltale signs, features of male hypogonadism. And we all have been discussing and concerned about the aging male and the testosterone deficiency, which apart from the reduced libido and oligospermia, the metabolic repercussions of same are equally important in such a scenario. So dear friends, I would just like to stop here. Should there be any questions, I'll be happy to take them.
Thank you, Dr. Ajay Shah. It was a very nice presentation. And not only the patients, attendants, many of the times, doctors at the periphery, they do not understand how this adolescent boy is not getting his facial hair or development of secondary sex characters. And many of the times it gets delayed, they get married. Even after marriage, they come for the fertility, and we find that they have hypogonadism right from childhood. So how clearly you have explained given the message that how we should see our patients right from beginning to not to delay the diagnosis and have complete management at the earliest when they can be diagnosed in the infantile period or neonatal period or adolescence or later on. And a variety of presentation you have shown that how these patients can occur. So message was very much clear. And any questions, if there are one in chat box, please.
Thank you, Dr. Ajay sir. I just want one question. At what age in the puberty, suppose a boy is in the puberty age at around 13 or 14 years of age. So at what age all the external sexual characters are fully developed if the boy having a normal testosterone level? Can you please tell, sir?
Normal for the age, I just tell you that there's nothing like normal values. These are the normal value for the age. We use the term delayed puberty if the first sign of puberty, that is enlargement of the testis beyond 4 ml, does not occur by 13 years of age. So that, and puberty is complete in 2.5 to 3 years. So that if by 15 nothing happens, we should start our evaluation at 13 years of age, particularly if there are other features as well of hypogonadism. I hope I was clear in answering your question.
One,
Okay.
yes, one query is in the chat was Dr. Bodhayan Das Munshi. He's asking that, could you kindly discuss the normal levels of various hormones like testosterone, LH, FSH, and interpretation of the levels when it is significantly high?
So my question is, how can you diagnose intrauterine hypogonadism?
You cannot diagnose intrauterine hypogonadism because the descent of the testis occurs only by 35th or 36th week, which means even after, sometimes even after birth. For example, if a child is born prematurely at 32 weeks, we cannot label him hypogonoid just on the basis of the finding that there is cryptorchidism. It could still occur on its own because for the gestational age, it could be there. However, if there are additional features, for example, a syndrome, for example, a Klinefelter syndrome, we know that it will be a hypogonad child. So either an amniotic biopsy or a karyotype of that patient, we can diagnose intrauterine hypogonadism.
One query is there in the chat box, Dr. Ajay. Dr. Bodhayan asked that, could you kindly discuss the normal levels of various hormones like testosterone, LH, FSH, and the interpretation of these levels when it is significantly high or low?
Okay, so the fetal levels have been used or interpreted only in research settings. Clinically, it is not feasible to measure. I mentioned that in infancy up till 6 years or maybe up to 8 years, testosterone levels could be high, up to reaching up to levels of 8 or 9 nanomoles per liter, which is the SI unit of the measurement of testosterone. And these are the levels at which time LH and FSH level, something like 2.5 to 3 international units per liter are there. After the puberty, that means after 13 years of age, testosterone levels are increased beyond 10 nanomoles per liter. And if the testosterone levels are less than 8, we can safely, after the age of 14 years, we can safely label a patient hypogonad based on the testosterone levels. The gold standard way of measuring testosterone is LCMS, liquid chromatography, mass spectrography. This is done by specialized labs for measuring gonadal steroids. That's the gold standard. Although by RIA and CLIA, we can still measure fairly accurately testosterone levels. Regarding the levels of LH and FSH, anything more than 3 of LH would mean a pubertal range, international units per liter. These are glycopeptides in contrast to testosterone, which is a steroid molecule, and the best way to measure the method used to detect LH and FSH is CLIA or a fluorescent assay. If there is a doubt regarding the pubertal status, we can do a stimulation test by GnRH or its analog. And if there is a protocol for it, And if the levels are pubertal range, more than 3 international or sometimes even 4 in some studies are taken, we can take it as a pubertal level of the gonadotropin. These levels are maintained in the adulthood up till 65 or 70 years, and they are like that. And in between 9 months of age to pubertal, the levels of testosterone, LH and FSH are undetectable. That is the normal values.
Thank you, Dr. Ajay, for putting an insight in clinical features of hypogonadism, how we have to suspect right from the beginning, and we do not miss, and we try to diagnose them at the earliest to give full advantage of the therapy so these patients can be benefited. And now we move towards the second talk of today's session. And for that, Dr. Sanjay Saran is with us. He is Associate Professor of Endocrinology in the Department of Endocrinology, SMS Medical College. He's a brilliant endocrinologist, and he will be speaking about various genetic syndromes and genetics about the hypogonadism, particularly two very common syndromes like Klinefelters and Kallmann. Dr. Sanjay, you please join.
Yes, sir. Yeah, good evening to everyone. First of all, I thanks to Dr. Keshwani sir for your kind introduction. Other thing is that I'm very thankful to organizers for providing me such a beautiful platform to express my all the things which I have just done to present in this scenario. So we will deal with genetics of hypogonadism. You know, genetics of hypogonadism is a vast topic. It's very difficult to cover in one talk, you know. So particularly we will deal on the genetics of idiopathic hypogonadotropic hypogonadism. And as the topic is mainly will cover the Kallmann syndrome, and other idiopathic also will deal with that. Again, the other topic is Klinefelter syndrome. So Klinefelter syndrome will do in the last, as it doesn't have the much more in the genetics. It's a chromosomal disorder, so it's not a big thing. So as far as hypogonadotropic, this hypogonadism we are concerned, you know, the hypothalamo-pituitary gonadal axis activity is very variable throughout the life. It's not the same kind of is going on. It's increased, particularly the earlier days where the mini puberty we will see, then again it remains constant, then again during the puberty it increases. So we know the gradual increase in the HPG, this activity, it brings out about the puberty. So around the age of around 10 to 14 years, in between that time, there is a gradual increase in the this SPG activity that causes secondary sexual characters and maturing the this reproductive system of the individual. So this specialized phase of this human development, it's called the puberty, and it usually lasts from the 2 to 5 years. Absence of puberty, it manifests as the lack of secondary sexual characters, sexual immaturity, and reproductive incompetence. So that is termed usually as the hypogonadism. Next slide, please. So hypogonadism we can classify into two types where the primary defect lies. It can be either primary hypogonadism or it can be secondary. In the primary hypogonadism, we know it is also known as hypergonadotropic hypogonadism, where usually the pathology lies in the gonads. And other is the secondary hypogonadism, where it is also known as hypogonadotropic hypogonadism, where usually the pathology lies in between, where the hypothalamus or in the pituitary. Mainly, it usually lies in the pituitary. Next slide, please. Now the clinical presentation, we know these are the various clinical presentations: fetal development, then neonatal, then childhood, then puberty. So as we were considering regarding the HPG activity in the initial phase, where we can say that we are saying in the neonatal period, the mini puberty, then later on it remains crescent, then during the puberty, it again get activated, then it remains activated throughout the adulthood. Next slide, please. Now, these are the various sites where the primary hypogonadism, where the testicular functions are disturbed, or we can say organ functions are disturbed. So because of lack of this feedback, the FSH and LH gonadotropins levels are raised. Where in secondary hypogonadism, pituitary or hypothalamic dysfunctions are there. Because of that, there is no drive towards the this gonads to secrete the testosterone or the estrogen. So their FSH, LH, and testosterone all are decreased. Next slide, please. So we are focusing our this presentation on the congenital hypogonadotropic hypogonadism. So we know there are many causes of hypogonadotropic hypogonadism. Can be surgery, or can be some infarction of pituitary, or maybe some trauma, or there radiation. There are a lot of causes are there. But we will particularly deal on the congenital hypogonadotropic hypogonadism, because we will see the genetics of these syndromes. So congenital, or we can say isolated hypogonadotropic hypogonadism, is usually defined as the absence of or arrest of puberty due to impaired gonadotropin releasing hormones or gonadotropin secretion, any without structural abnormality or structural damage to the region, and the other pituitary hormones are not disturbed. So about half of these patients are having some disorder of smell, anosmia or hypopsmia. So they are known as Kallmann syndrome. So due to the defective embryonic migration of the GnRH synthesizing neurons along with olfactory neurons from the olfactory placode, we know these hypothalamic neurons, these GnRH secreting neurons and olfactory neurons, they are just developed near the olfactory placode simultaneously. And along the olfactory pathway, then later on they migrate. So the defective migration can cause this defect in the smell or defect in the gonadotropin, this GnRH synthesis and secretion. So CHH patients with the normal sense, they are also 50%, around 50% are having normal sense. So they are labeled as a normosmic isolated hypogonadotropic hypogonadism, like NIHH and IHH. Next slide, please. So now come to the genetics of this congenital hypogonadotropic hypogonadism. So genetically, it is very heterogeneous. We know it can be sporadic, or it can be familial, it can be X-linked recessive, autosomal recessive, autosomal dominant, with all kind of this this inheritance can be there with them. It may be low penetrance or variable expressivity can be there. Even in the single family, we can see the variable expressivity are there of this CHH. Or other thing is that we can see the various associated features. They can be variable, like cleflet. In one member cleflet is another member, it's not there. It can be like that. So first gene that was associated with Kallmann syndrome was Kallmann gene. So that is now it is known as ANOS1 gene. So it was identified in 1991. To date, more than 25 genes have implicated in the Kallmann syndrome, and remaining around 25 to 30 genes are implicated in the NIHH. So total around we have the 60 genes which are implicated in the associated with the congenital hypogonadotropic hypogonadism. Out of that, 25 genes are associated with Kallmann syndrome. So CHH is classically, it's a monogenic disorder, but in 20% of the cases, may be oligogenic. Next slide, please. So now come to the Kallmann syndrome. So Kallmann syndrome is often due to embryonic maldevelopment or interruption of migration of GnRH specific neurons. Now, it cases, they often presented with additional congenital abnormality, such as the cleft palate, unilateral renal agenesis, split hand and feet, and short metacarpal. Deafness and mirror movements are also there. So these all are different features are there with the Kallmann syndrome. They can be because of the different genes which are involved in the occurrence of this Kallmann syndrome. Next slide, please. So this is the common pathophysiology of Kallmann syndrome. From the nasal placode to the their definitive place in the hypothalamus, these GnRH neurons cannot reach, or defective migration is there, or maybe defective development can be there. So these are the various genes like Kallmann gene, FGF8, FGFR1, this PROC2. These are various different kind of genes which are implicated in the occurrence of this Kallmann syndrome. Next slide, please. So now currently we know the genetic defect in up to 50% of the IHH cases. Rest 50% are still idiopathic. We do not know this genetic defect. So idiopathics are all, but the genetic defect we know only on 50% of the patients. So to date, around 50 genes have been implicated in causes of IHH. Presence of more than one IHH-associated mutant gene in a parent or single pedigree can occur in about 10 to 20% of the cases. Next slide, please. Now, Kallmann associated genes. So Kallmann syndrome, it can be X-linked recessive, autosomal dominant, or autosomal recessive, or it may be sporadic or familial or substantially variability of the clinical phenotypes we can see among the same family of the affected member in the same family. Next slide, please. So first is the NSO1. This is also known as Kallmann gene. It encodes for the extracellular glycoprotein called anosmin. So that is the glycoprotein for the cell member that forms a cell membrane. So it is associated with the cell membrane by heparin sulfate proteoglycans. So 10 to 20% of the males with Kallmann syndrome carry Kallmann mutations or this intragenic microdeletion in this Kallmann gene. It is X-linked recessive. It's more severe, but it's less variable. It's the most common gene which is associated with the Kallmann syndrome. So accompanying features with this Kallmann gene are synkinesia, unilateral renal agenesis, which usually occur around 75% of the cases. We see synkinesia is very common in our clinical practice also. We have seen many of the cases. So renal agenesis can also be seen in 30% of the cases. Next slide, please. So considering these all features, if the patient of hypogonadotropic hypogonadism we see, we should search out these features also to know where to go for the which genetic testing should be done in such kind of the patients. So next gene is FGFR1 and FGF8 and related genes. These are various related genes. So FGFR1 we have seen particularly on the this bone and cartilage. So it requires for the HSPG as a co-receptor and anosmin-1. So anosmin-1 is like to play the key role in the mediating the FGFR1 signaling. So loss of FGFR1 function has also been reported to elicit the productive abnormality. It can range from the severe autosomal dominant Kallmann syndrome through the fully penetrant NHS to delayed puberty. So a lot of variabilities can be seen with the expression of this gene because the two genes are involved, particularly FGFR1 and also anosmin, because it requires anosmin. So two are said. So where a variable expression can be there. Around 10% of the patients with Kallmann syndrome were found to having the inactivating mutation in the FGFR1 gene. Loss of function mutation in FGFR1 are detected in around 7% of the patients. Next slide, please. So these are various two more important. The other important genes are also there. That KLB. This is the most recently reported fibroblastic growth factor related IHF gene. So it is known as it encodes for the beta klotho. It's a co-receptor in the FGF21 signaling pathway. So it's a majority of the patient with KLB mutations exhibit some degree of metabolic defects like the insulin resistance and dyslipidemia. Now the KLB, it knockout mouse model also reveals the milder hypogonadism and also compared to the corresponding human phenotype they have seen. Next slide, please. Now come to the ProKR2 and ProK2 genes. So these genes encodes around two proteins. They signals by the G protein coupled receptors. The inactivating variants of these two genes were detected in the Kallmann syndrome patients. Most of these mutations were heterozygous, although homozygous and compound heterozygous, these mutations have also been described. So again, two genes are there, so considerable phenotypic variability is also there, ranging from the Kallmann syndrome to NIHS. It is associated with the fibroid dysplasia, synkinesia, and epilepsy. Next slide, please. So now again, this CSD7, this encodes for the chromatin remodeling factor as a mutant gene seen in the CHAR syndrome. We know CHAR syndrome is a constellation of coloboma, heart anomalies, corneal atresia, this growth retardation, genital and ear abnormality, this CHAR syndrome. So many of the CHAR syndrome we have seen, they may be having this isolated hypogonadotropic hypogonadism. So it is recommended that any patient with CHAR syndrome, we should search for this delay in the puberty also. Next slide, please. Now again, the next gene is WDR11. So again, this is the product of this EMX because of homeodomain transcription factor. So it's also involved in the development of the olfactory neurons. By the positional cloning, heterozygous mutations were discovered in several patients of the Klinefelter syndrome having this gene. Recently, a digenic combination of these monoallelic variants, ProK2, this WR11, they were reported in the responsible for the pituitary stalk interruption syndrome in child. Next slide, please. Now come to this SEMA3A. Again, they are encodes for the protein semaphore 3A. Screening of large group of Kallmann syndrome have revealed the variety of monolithic mutations. We are discussing these SEMA3A and this SEMA3E these genes because of they are having variable these phenotypic features. On these phenotypic features, we can suspect that such kind of the genes may be involved, so we can go for the this kind of genetic testing. And again, phenotypic features may present later on, so we should be aware of that phenotypic features. Next slide, please. Now again, SOX1 it's not very unknown. So inactive mutation in the SOX this 10, it causes the Waardenburg syndrome. So again, the rare disorder, it is characterized as pigmentation abnormality and hearing impairment. So this is also found in this Klinefelter syndrome in around 1/3 of approximately patients who reveal with deafness, presented with deafness in 1/3 of the patients, this SOX10 mutations was found. So again, agardigin in this HS6ST1. So again, this also the forms of enzyme, especially and randomly it modifies heparin sulfate. So heparin sulfate, we know it requires the optimum cell communication. So again, the inactivation is associated with Kallmann syndrome mutants. This is also reported in many of the families of Kallmann syndrome. Next slide, please. So most of these genes are reported in the consanguineous family, in the particularly some regions like Pakistan or some Gulf regions or Iran. So now come to the DC, this 141 is again encodes for the coiled domain containing proteins that is expressed in GnRH neuron. Again, they have reported the inactivating mutation in the 4 of separate family IHH. So still the work is going on this genetic detection of the various mutations on the IHH. We know only 50 genes were discovered, so still many are undetected. So here also, this affected individual, they have the normal olfactory function, but the again normal anatomically olfactory bulb also there. So again, other gene is this FEGZF1 that encodes for the transcription repression. So again, it is expressed during the embryogenesis in the this olfactory epithelium, amygdala, hypothalamus here. So here also many of the around 30 of the individuals were detected as this mutation in the FEGZF1 genes. Next slide, please. So now this one also IGSF110, it's a member of hemoglobin family. So these were also detected in more than 100 individuals with delayed puberty and identified the mutations with the IGSF1. So again, knockout study have shown that reduced GnRH migration in the GM11 cell lines. So the reduced number of the delayed arrival of the neurons in the hypothalamus. So milder variety can be there. We know this hypo around 10 to 20 patients percent of the patients are reversible. So we are starting with the this hormonal therapy, testosterone, or we can say estrogen in the patients who are in hypogonadotropy, hypogonadism. Later on, we can say 10% of the patients, 10 to 20% of the patients can be off therapy. They are reversible. So such kind of genes are involved in the reversible this hypogonadotropic hypogonadism. So mutations, if identifying such kind of mutation, we can see such kind of mutation of functional hypothalamic this amenorrhea also. So we know that functional hypothalamic amenorrhea is also a very reversible entity. Next slide, please. So this is again other genes involved, SMCHD1. So again, these are also demonstrated in the various family. Great majority of the patients also had the hypogonadal features like Autoregulation. Next slide, please. So these were various genes which were implicated in the idiopathic hypogonadotropic hypogonadism with hyposmia or anosmia, that is known as Kallmann syndrome. So what is the significance of detecting such kind of genes? Why do we go for this genetic testing? So first is scientifically, if we're thinking, why should we go? So undoubtedly, we know the thing is that the GnRH pulse generator, with the searching of such kind of genes, the study were going on particularly GnRH pulse generator. This surge of study has occurred after knowing the kisipeptin and this NKP signaling. So following the identification of their inactivation mutations among the family members of NIHH, we know the lot of research are going on or well done for the this particularly on the GnRH this is stimulator. Now the stimulatory NKB that start in action potentials that is the suppressed by the inhibitory dynorphin. So next slide please. So when overcoming such kind of this inhibition by the NKB action that takes over, so there is different kind of action potentials are there. So the net result is continuous and intermittent action potential of these various action, small action potential. Then each action potential translates into pulsatile secretion of kisspeptin on the axons of the GnRH neurons in the median eminence. Then GnRH is released towards the pituitary gonadotropin by the portal circulation. Then gonadotropins are released. So synchronized this KNDY cells is believed to be provided by the NKB-NKBR signaling through the psi and contralateral projection among these cells. So they causes the secretion of this pulsatile GnRH and then pulsatile gonadotropin release. Next slide. So that comes about the causing the puberty, that causes the release of these gonadal hormones. So now come to the this clinical significance. What is the clinical significance of identifying such kind of gene or this genetic mutations? So we know clue to targeting the diagnostic molecular genetics. So in which patients, which targeting, which molecular testing we should go. So once we know that the patient is in cleft or patient is in some lineal agenesis and anosmia is there. So we can think of particular genes that this gene may be involved. So we can go targeting molecular, this genetic studies on that gene. So again, GnRH receptor and this TACR3, they should be the first two genes to be screened because they are involved in most of the cases of Kallmann syndrome. So they should be the first genes to be screened. If we do not know regarding this, that switch gene, we cannot suspect that particular gene, then these should be the first two genes to be suspected in the patient of Kallmann syndrome. So according to the presence of this certain accompanying clinical features, genetic testing screening for the particular genes can be prioritized. For example, if the patient is in synkinesia, then Kallmann gene should be suggested. If the patient is dental agenesis and associated, it is associated with the FGF8 or FGFR1 genes. And if the patient is in digital abnormality, they also can be associated with the FGF8 or FGFR1 this gene. And if the patient is in hearing loss, then we can see CHD7 or SOX10 genes. So regarding the detail of these genes, I have already explained. So because of that, we need the genetic testing and we need to know regarding these different kind of genes. So again, we are saying IHS, the workup on the IHS is incomplete, we can say, without knowing the different genetic defect. So IHS is associated with the gene study, maybe translated into new therapeutic modalities. Like if the patient is some particular mutations like TACR3 gene product, it has been in the clinical trials with the polycystic ovarian syndrome. Next slide, please. So we can divide this congenital isolated hypogonadotropic hypogonadism in two parts. One is anosmia and hyposmia associated, another one is normosmia. So anosmia and hyposmia associated genetic evaluation we have already done here. And now the normosmia and this normosmia, where the smell is normal, genetic evaluation, the same kind of evaluation we do. Many of the genes which are associated with the Kallmann syndrome are here also, they are associated. Many different genes are like leptin genes or leptin receptors, kisspeptin receptors. There are some different genes are there. They are also associated here with the hypogonadotropic hypogonadism with normosmia. Next slide, please. So these are the various most commonly implicated genes with the hypogonadotropic hypogonadism associated with hyposmia or anosmia. So the inheritance is X-linked, autosomal dominant, recessive are there. So we have already explained regarding these genes, or few genes or other are also there. So they are not so common. So we have not discussed on those genes. Particularly around 25 genes are there, but we have discussed on around 10 to 12 genes. Next slide, please. So these are various different kind of other genes which are associated with the IHH. Next slide, please. So now come to the Klinefelter syndrome. So this was the other part of our study. You know, the Klinefelter syndrome, it's one of the most common sex chromosomal abnormality that is in the population. We know if we are saying it's an iceberg, it is most of the cases around up to 70 5% of the cases in adulthood are undiagnosed with Klinefelter syndrome. It's so common. So it's characterized by presence of one or more extra X chromosome. Next. So chromosome complement we can see in the 46XXY. In 90% of the patients, the chromosomal analysis karyotype shows 47XXY. It's the most common. Otherwise, there may be mosaicism also there. So in the mosaicism, different cells, different karyotype can be there. In some cells, it can be 46XY, and some other cells, it can be 7XXY like that, or maybe some different. So phenotype is male. Next slide, please. So incidence is 1 into 6 to 700 cases. Next slide, please. So this is the history that Dr. This Klinefelter described the 9 patient gynecomastia azoospermia with this Klinefelter phenotype, but he could not know what the cause. But later on, by the Brodry, he found that the 2 sex X chromosome were there in the patients of Klinefelter syndrome. So next slide, please. Klinefelter syndrome is the most common cause of primary hypogonadism. So these are various clinical features of Klinefelter syndrome. So main features are tall stature, thin build is there, shoulders are narrow, hip is wide, and this Hpogoadism is there. Length of the head, this upper limb and lower limb is more as compared to the upper torso. So upper torso is not more because of the spine is there, so length of spine is not increased in Turner syndrome. Testicular atrophy is the most common feature. Small firm testes are there, and then the gynecomastia is there. Low level of intelligence. So IQ is decreased in the terms of 10 to 11 points. So again, high pitched voice is the infertility is obvious. Next slide, please. Next slide, please. So now come to the genetics of this Klinefelter syndrome. So due to one more extra X chromosome in the phenotypic male, this is the cause of the Klinefelter syndrome. So we know this extra chromosome, we know the CTG repeat is there. So we know the CTG length, if it is short, it is better. If it is longer length, it is more dangerous. So decreased IQ will be there, and these features of the Klinefelter syndrome will be there. So more length of the CTG, this repeat, and more this severity of this Klinefelter syndrome will be there. So now it is due to biotic non-disjunction of X chromosome during that gamete formation. Maternal or paternal can be there, 50-50% in both it is there. So increased maternal age is associated with the increased risk of Klinefelter syndrome. Same as with the increased paternal age is also associated with the increased risk of Klinefelter syndrome. Next slide, please. So now again, 75 to 90% of the patients are having this 47XXY karyotype. Rest are having mosaicism. So this androgen receptor is encoded by the S chromosome, we know. So the length of this Cas repeat on the androgen receptor is inversely associated with the androgen effect and cause the variable phenotype in the Klinefelter syndrome. Next slide, please. So this is the karyotype of Klinefelter syndrome. This all regarding genetics of Klinefelter syndrome. Next slide, please. So treatment part, we are not going with the treatment part. So maybe nowadays we know the Klinefelter syndrome patients are not so infertile because we have various modality of the treatment we are having. We can remove the sperm from their this testis and inject in the cycle by the ICSI, We can do this testicular sperm extraction, TSET we do, and then after ICSI we can do. So again, there is a azoospermia. Mostly we see maybe somewhere this oligospermia. At that time we can preserve the sperm also. So treatment is also there for the infertility. Regarding other thing, we know that this testosterone replacement therapy. Various kind of testosterone we have. This oral testosterone, injectable, various kind of injectable, long-acting, undeponated, the testosterone we are having, and patch are also having some buccal. This patch is also we are having. Gel is also we have. Next slide, please. So thank you. This all regarding Klinefelter syndrome and Kallmann syndrome genetics. Sir, unmute yourself.
Thank you, Dr. Sanjay, for giving a detailed abnormalities which by genetics can cause hypogonadism. And clinically, we can see 2 kinds of the hypogonadism: idiopathic hypogonadotropic hypogonadism or hyper one. And very well told that we should suspect hypogonadism with the certain other genetic abnormalities like short fourth, metacarpal, ear abnormalities, or microphallus or cryptorchidism right at the time of the birth, and later on with the long-leggedness, unicoid proportions. So we can suspect that these patients are going to have hypogonadism, and we can intervene and investigate right from the beginning. And it was a nice presentation. And any questions from the audience, if are there, they are welcome. So as there are not any questions, can Sanjay, as you told that by ICSI we can cause fertility in patients with the Klinefelters. So what will happen to the next generation regarding the chromosomal abnormalities?
Yeah, sir, it's a very big question regarding because the Klinefelter syndrome patients, their chromosome is also defective. And another thing is that the Klinefelter syndrome patients are having other abnormality also, other genetic effect also. So again, these are the questions. For that, we required some genetic counseling first before doing such kind of this treatment. Genetic counseling is must in Klinefelter syndrome. Because the next generation also can be there the same thing, or maybe some other genes which are affected in the Klinefelter syndrome patients can be detected and can go in the next generation. So this genetic counseling is recommended.
So proper counseling is a must before going for that procedure, right?
Yes, sir. Yes, sir. We are doing the procedure like ICSI, so we should be very clear regarding that the patient is not having some genetic abnormality or something that disease which is permanent to the upcoming state.
Thank you, Dr. Sanjay. You have given good illustration of various clinical symptoms. And an adolescent, if he is growing very tall beyond proportions, then we should not be very happy, and we should try to work up these adolescents also for the hypogonadism and for many other clinical abnormalities. And this was a nice presentation, and thank you, Dr. Sanjay and Dr. Ajay Shah, Dr. Minal. And now I hand over to our patron, Dr. KK Parikh sir, for your nice words.
Excellent presentation by Dr. Sanjay and Dr. Ajay about hypogonadism, and very well cleared about concepts about these diseases, and it had been a real updating of knowledge to our clinicians. So thank you again, Dr. Sanjay and Dr. Ajay, for sparing your valuable time and to come on this CLA. Thank you very much, and thank you very much, Minal, for giving a very good concepts about thyroid functions and everything. And last but not the least, Dr. Prakash Keshwani, for organizing such a wonderful initiation of this CME programs, which will go on educating our clinicians not from Rajasthan, but all over from India. I see a lot of persons from lot of clinicians from other places also. So compliment Dr. Prakash.
Thank you, sir.
Congratulate you for initiating a good.
This is all here because of motivation by yourself for a very long time. And next week, many of the, including Dr. Minal, will not be in town because of the going to Calcutta. And our next session will be on the 3rd July. And same timings, 2 to 4 p.m. Thyroid Symposium, followed by 2 speakers on the male hypogonadism, including Dr. Madhukar Mittal, who is professor of the endocrinology at AIIMS, Jaipur, and Dr. Rakesh Sai, professor of endocrinology at Nizam's Osmania Institute of Medical Sciences, Hyderabad. But till then, we leave. Bye-bye, everybody. Thank you, sir. Thank you, Parikh sir. Thank you, Sanjay. Thank you, Ajay Shah. Thank you, Dr. Minal. Bye-bye, everybody.